Myasthenia gravis is an autoimmune disorder. Look at this picture, shows that disease mechanism. CT findings and MRI. Detail going on. Introduction. MG is a chronic autoimmune neuromuscular disorder characterized by weakness in skeletal muscles, which are responsible for voluntary movements. The hallmark of MG is muscle weakness that worsens after periods of activity and improves after rest. MG affects the communication between nerves and muscles, leading to progressive muscular fatigue. Definition. Myasthenia gravis is defined as an autoimmune disorder where antibodies block or destroy nicotinic acetylcholine receptors ACHRs at the neuromuscular junction, preventing nerve impulses from triggering muscle contraction. This results in muscle weakness, which can be localized or generalized depending on the severity and progression of the disease. Types. 1. Ocular myasthenia gravis. Muscle weakness is limited to the muscles that control eye and eyelid movements. Symptoms include dropping of the eyelids and diplopia, double vision. 2. Generalized myasthenia gravis involves multiple muscle groups beyond the eyes, including muscles responsible for facial expression, speech and chewing, swallowing, neck and lip movements. 3. Congenital myasthenia gravis. This is a rare form caused by genetic mutations affecting proteins involved in neuromuscular transmission. It present from birth. 4. Juvenile myasthenia gravis, a form of MG that develops in children, often presenting with ocular symptoms. 5. Transient neonatal myasthenia gravis occurs in newborns of mothers with MG due to the passive transfer of maternal antibodies to the infant. Causes The exact cause of MG is unknown, but it is an autoimmune condition in which the body produces antibodies that interfere with communication between nerves and muscles. The immune system attacks acetylcholine receptors or lapsed proteins, disrupting the normal functioning of muscle fibers. The thymus gland is often abnormal in people with MG and may play a role in the autoimmune response. One acetylcholine receptor antibodies. These antibodies attack ACH receptors at the neuromuscular junction, blocking muscle activation. 2. MUSK antibodies, muscle specific kinase, MUSK. Antibodies attacks protein involved in neuromuscular transmission. 3. Thymus abnormalities. The thymus gland is abnormal in most MG patients, often enlarged, containing thymomas or tumor. Risk factors. 1. Age. MG can occur at any age, but is more common in women under 40 and men over 60. 2. Gender. Women are more frequently affected by MG, especially in younger age groups. 3. Genetics. Although MG is not hereditary, genetic predispositions to autoimmune diseases may increase susceptibility. For other autoimmune disorders, people with other autoimmune diseases such as rheumatoid arthritis or lupus are at higher risk. Complications. On myasthenia gravis, a severe exacerbation of muscle weakness that affects breathing and requires emergency medical care. 2. Respiratory failure. Weakness in respiratory muscles can lead to life-threatening breathing difficulties. 3. Thymoma. A tumor of the thymus gland seen in some patients with MG. 4. Ocular complications. Uncontrolled MG may lead to prominent eye muscle weakness or vision loss. Pathophysiology. In MG, the immune system creates antibodies that either block or destroy acetylcholine receptors at the neuromuscular junction. Normally, acetylcholine binds to its receptors and stimulates muscle contraction, but in MG, fewer receptors are available due to the antibody attacks. This decreases the efficiency of neuromuscular transmission, resulting in muscle weakness. The muscle weakness worsens with activity due to the duplication of acetylcholine at remaining functional receptors. The thymus gland, which plays a role in immunosystem regulation, may produce autoantibodies in MG patients. Approximately 75% patients have thymic abnormalities, including hyperplasia or thymomas. Pathophysiology of myasthenia gravis (MG) step-by-step process. 1. Autoimmunoresponse activation. 2. Antibody binding. 3. Receptor blocked. 4. Receptor destruction and degradation. 5. Reduced synaptic transmission efficiency. 6. Muscle weakness and fatigue. 7. Role of thymus. 8. Muscle specific antibodies. Alternative mechanism. This step-by-step breakdown highlights the autoimmune attack on the neuromuscular junction, which lead to the primary symptoms of MG: muscle weakness and fatigue. Signs and symptoms. 1. Muscle weakness, the primary symptom in muscle weakness, which typically worsens with activity and improves with rest. 2. Ptosis, dropping of one or both eyelids. 3. Diplopia, double vision due to weakness in the muscles that control eye movement. 4. Facial weakness, difficulty with facial expressions, smiling or frowning. 5. Dysphagia, difficulty swallowing. 6. Dysarthria, slurred speech or trouble speaking clarity. 7. Lymph weakness, weakness in arm, legs and neck muscles leading to difficulty in walking or holding up the head. Diagnosis. 1. Clinical examination, a detailed history of fluctuating muscle weakness and physical examination is essential. 2. Tansulon test or hydrophonium test, a short-acting drug that temporarily improves muscle strength in MG patients. 3. Electromyography EMG, a test to assess electrical activity in muscles. 4. Serological tests, detection of anti-AChR and anti-MuSK antibodies in the blood. 5. CT or MRI scan imaging studies to detect thymomas in the thymus gland. 6. Pulmonary function test to assess respiratory muscle strength. Nursing diagnosis. 1. Impaired physical mobility related to muscle weakness. 2. Risk for aspiration related to impaired swallowing and muscle weakness. 3. Ineffective breathing pattern related to respiratory muscle weakness. 4. Fatigue related to activity induced muscle weakness. 5. Anxiety related to chronic nature of the disease and fear of exacerbations. Disease management. First, medical management. 1. Anticholinesterase inhibitors. Medications like ferridoxstigmine improve communication between nerves and muscles. To immunosuppressants, prednisone, azathioprine or cyclosporine to suppress the immune response. 3. Plasmapheresis, a process to remove antibodies from the blood, providing temporary relief. 4. Intravenous immunoglobulin IVIG provide antibodies that alter the immune response. 5. Thymectomy, surgical removal of the thymus gland, which can improve symptoms or leads to remission in some cases. Nursing management. 1. Monitor respiratory status. Regularly assess respiratory functions, including oxygen saturation and lung sounds. To assist with mobility, encourage rest, provides and assist in activities of daily living to avoid fatigue. 3. Monitor for dysphagia, assess swallowing and provide appropriate dietary modifications to prevent aspiration. For patient education, teach about medication management, energy conservation techniques, and recognizing early signs of a MYASTHENIA crisis. Treatment. 1. Medications. Anticoagulant stress inhibitors, corticosteroids, immunosuppressants. 2. Surgical thymectomy. 3. Plasmapheresis and IVG used in severe or refractory cases. For respiratory support in cases of respiratory failure, mechanical ventilation may be required. Psychosocial medicine. Patients with MG may experience psychosocial issues such as anxiety, depression, and social isolation due to the chronic nature of the disease. Support groups, counseling, and patient education are vital in managing the emotional impact. Nurses should address the emotional needs of patients, offer support, and encourage open communication with family and caregivers. Prevention. There is no known way to prevent MG, but managing triggers such as infections, stress, and overexertion can help prevent exacerbations. Regular follow-ups and adherence to treatment plans are essential in preventing MYASTHENIA crisis. In conclusion, MYASTHENIA gravis is a manageable yet chronic autoimmune condition that significantly affects muscle function. Early diagnosis and combination of pharmacological treatments, surgical interventions, and supportive care can improve the quality of life for individuals living with MG. A multidisciplinary approach is essential for comprehensive care with attention to both physical and psychosocial aspects of disease. Thank you. Have a nice day.